My name is Hale Kahyaoğlu. We're working together in the Balıklı Greek Hospital with I-10. I'm going to talk about psychotherapeutic approaches in post-traumatic stress disorder patients. Now, let's look at the historical definition of trauma. Historically, a traumatic event has commonly been described as a sudden and unexpected occurrence associated with a threat to life or physical integrity and outside of the normal range of life experiences. And there are some examples to this. What is PTSD? What causes PTSD? Child abuse, natural disaster, mass violence, serious accidents, fires, war, rape, terrorist acts, other violent personal assaults can all cause PTSD. When we ask what is PTSD, it's a psychiatric disorder that can occur in people who are directly exposed to traumatic event or who have witnessed a traumatic event. As we said, terrorist acts, serious accidents, and other examples I have mentioned a few seconds ago. According to the DSM-5 definition, you know very well that the exposure must result from one or more of the scenarios listed on this page, like directly experiencing the traumatic event. Another one is witnessing the traumatic event, or learning that traumatic event occurred to a close family member or a close friend. And this could be that we're talking about a serious death or threat to life, or experiencing some other violent or accidental events, and experiencing the repeated or extreme exposure to the aversive details of the traumatic event are also causes. Looking at PTSD in children, we see it can show intrusive, avoidant, emotional numbing, hyperarousal symptoms accompanied by pervasive changes in mood, cognition, and self-concept. Related symptoms may include depression, anxiety, impulsivity, aggression, hyperactivity, agitation, irritability, behavioral issues, sleep difficulties, and attention deficit problems causing or impairing daily functions. When we look at the reported overall lifetime prevalence of post-traumatic stress disorder, it is between 3 to 9%, and it varies by gender, with approximately 4% of male adolescents and 7% of female adolescents. American and European studies suggest that 14 to 67% of studied children experience at least one traumatic event before they reach adulthood. The majority of these children do not suffer from long-term negative effects of trauma. However, about 0.5 to 3% of them develop full post-traumatic stress disorder, and 13% suffer from some symptoms of post-traumatic stress, according to the research of Hale. There are some behavioral symptoms that accompany PTSD. There are 4 of them: re-experiencing, avoidance, negative cognitions and negative mood, and hyperarousal. Looking at risk factors and predictors of post-traumatic stress disorder, it's associated with comorbidity with physical and mental health issues and may elevate the risk of suicidal behavior. Risk and protective factors for PTSD can be conceptualized from pre-traumatic or traumatic events or post-traumatic symptoms or factors. The likelihood of developing PTSD was higher in patients who were exposed to subsequent traumas than ones who haven't been exposed to subsequent traumas. So if there's physical abuse in childhood, we know that if it's followed up by subsequent physical violence, the PTSD occurrence risk is higher. Women are much more likely than men to be exposed to partner sexual violence, And married women have significantly reduced probability compared to the vast majority of married women, and low education is associated with elevated risk. And we see that at age 17, interpersonal violence, median age is 17, 18 is intimate partner sexual violence. War-related traumas, median age is around 20, and between 24 to 31, we're talking about unexpected death of loved ones. I'd like to talk about the main issue here, and that is the therapeutic approaches to trauma. Well, firstly, let's focus on some therapy methods. First is prolonged exposure. It's focusing on altering the structure of fear so that it's no longer problematic. This is an evidence-based method, though in literature it's said that it is typically completed in 8 to 15 sessions. This method of therapy has 3 different methods. One of them is in vivo exposure, helping the patient to approach situations, places and people they have been avoiding related to this trauma. Imaginal exposure consists of patients approaching memories, thoughts and emotions about the traumatic event. Here, patient is expected to retell the narrative of the traumatic event in the present tense repeatedly, and tape record this practice for imaginal exposure as homework or as an exercise. This imaginal exposure shows that the emotional content that is processed emerges during this exposure. So the patient who has applied about trauma is informed and exposure is discussed. Also, breathing training is crucial as well. Dealing with stressful situations is crucial for dealing with stressful life events. Again, very commonly, trauma therapy that is very common is trauma-focused CBT, including behavioral techniques such as exposure, cognitive techniques, and restructuring. Also, it uses imaginal exposure, like writing the traumatic narrative or reading the traumatic memory loud, or teaching the patients to identify what triggers re-experience. And cognitive restructuring focuses on teaching patients to identify the thoughts and thinking errors that happen now and in the past. By eliciting rational, alternative thoughts and rephrasing beliefs about themselves, the world, and the trauma. In trauma-focused CBT, there is an acronym called PRACTICE. Psychoeducation is the first target. Parenting skills, relaxation skills, affective modulation skills, cognitive coping, trauma narrative and cognitive processing of the traumatic event, in vivo mastery of trauma reminding, joint child-parent sessions so that trauma is restructured, and enhancing safety for the future developmental trajectory. This was proposed by Cohen and colleagues a decade ago. Let's focus on EMDR therapy. Eye movement desensitization and reprocessing therapy is a treatment for trauma developed by Dr. Francine Shapiro in the late 1980s. There's a correlation between eye movements and the cerebral capacity to process distressful thoughts and feelings. That's what Shapiro said initially. EMDR has a protocol, 8-legged protocol. History is taken, past medical history is observed, and the patient is prepared and informed about EMDR. and psychoeducation about trauma is administered or given, then pre- and reassessment, or what they call touchstone, is carried out from the moment where trauma occurred. Then before we start working on trauma itself, we focus on a safe place, and after that we make sure that we install sources. If it's a single traumatic event, we can just mitigate it to one event, and it may be a complex trauma. And if trauma is very highly loaded, and you could take it piece by piece, or you could have a more integral approach. Emotions, beliefs, and physical sensations experienced at the time of the event may be stored inappropriately in the episodic memory. And then we ask the patient, what is the negative belief about him? He might end up saying, or she might end up saying, I'm impatient, I'm not successful, I have failed, let's say. And then we could talk about a belief that could be replaced. And then we try to replace that belief with a more positive one. And also, processing involves short exposures of approximately up to 25-30 seconds with 20 to 30 sets. We compare this with sets of bilateral eye movements causing decreases in arousal, like we could tap him on the shoulder. The method we're going to use or the devices we're going to use may vary. Patients or clients are instructed to let whatever happens happen, as new thoughts, emotions and sensations, even dreams, may emerge. After each set, they are asked to report what came to their mind, and overall, the treatment includes processing past memories, present triggers and future challenges. Even if there is not a lot of research with EMDR on children, we see that EMDR can be applied together with play therapy to give us more efficient results. They are both powerful evidence-based methods of therapy. So, in traumatic processes for the children to get over this process, it could be used. Many events may emerge in play therapy, like traumatic experiences or traumatic events, and the emotional experiences of the child may emerge. And here, younger children process the memories more rapidly. So in 3 to 5 sessions, we can get results in children, but in adults it may go up to 10 to 15 sessions. Play therapy provides the clinician with the chance to install resources during play. So the child can say that this toy is strong and I'm very powerful. So you could tap the child on the shoulder, or you could use puppets to make sure that there are stimuli on his hands and the knee, making sure that this term or this concept is installed. So a child who actually doesn't feel strong enough may start feeling strong enough with this installed resource. Let's talk about family therapy a little bit. Trauma affects groups of people, not just individuals, and family systems, neighborhoods, and all the content of the family is affected. Even whole generations may feel the results of psychological trauma. And family psychotherapy is crucial, as it is a multimodal approach to post-traumatic stress disorder treatment. Family psychotherapy provides huge opportunities for social support, reintegration, and improvement of the mood. When trauma affects a whole family, or even a single member, the entire family suffer the result. And primary parenting functions of the protecting, loving, teaching, etc., all become disturbed. Trauma disrupts attachment bonds and severs important internal and external connections. And family therapy offers the opportunity to the family to make sure that they provide the safe, effective modulation that is required more than adequately in this situation. And also, psychosocial improvement is required for producing healing, psychological and psychosocial healing to social wounds, and also specifying. We could wrap up, I think, but it's almost about to finish anyway. Right, let me move on. The role of therapist in family therapy is very important, and now a trauma victim, for a trauma victim, the role of therapist should not be like a savior. And therapist, if that is required, should try to help to move past the traumatic experience, mentioning potential traumatic risks and how those risks could be avoided. Untreated post-traumatic stress disorder may lead to development of anxiety, mood, or substance use disorders. To prevent these long-term adverse effects, treatment of post-treatment stress disorder is crucial. Thank you very much.